Thank you for inviting me to talk to you today about the response to COVID-19 in England. You'll note that I'm referring to England and not the United Kingdom because the four parts of the United Kingdom, England, Scotland, Wales and Northern Ireland, have responded in quite different ways. So I'm just going to focus on England. The subtitle is Dithering and Disorganisation, and I think you'll see in a minute why I have used those rather critical terms. Let me start with the timeline. As you know, the first cases of COVID were confirmed worldwide in January and soon after in the United Kingdom. We then had a period of time as cases were rising, and in March the government advised anyone with a new continuous cough or a fever to self-isolate, and eventually it locked down on the 23rd of March. The peak of the pandemic came in April, and by May the government was beginning to relax the lockdown. By June they were allowing gatherings out of doors to take place and were beginning cautiously to reopen schools. And by July, the restrictions were being lifted in many other ways. Now, of course, we're seeing a reimposition of many of those restrictions. It's important to have some background. The United Kingdom did not come into the pandemic in a good way. Since 2010, successive governments had pursued a policy of austerity in the aftermath of the global financial crisis. Spending on the National Health Service had continued to increase, but it was far slower than before. There had been very large cuts to social welfare, to local government, to education and to other sectors. There had been a very large increase in insecure employment, in people who were on what were called 0 hours contracts, who did not know from one week to the next how much they would be working and how much they would be earning. In 2012, the government engaged in a major reorganisation of the National Health Service. This was extremely disruptive. It fragmented the health system. Lines of accountability became very unclear. Public health was moved from the National Health Service to local government. This was even more disruptive, and it subsequently experienced severe budgetary cuts. Some more background. Since 2010, there had been large cuts to the civil service, with many activities contracted to outsourcing companies. This led to repeated failures, and this was exemplified by the security operation at the 2012 Olympics. The military had to take over whenever the company G4S was unable to cope. In 2016, the United Kingdom voted to leave the European Union, what we now call Brexit. Unfortunately, there was no clear idea in government about what this meant or what politicians wanted. Their policies were driven by a xenophobic media and by extremist nationalist politicians within the governing party and on the right wing. Ministers made mistake after mistake, a whole catalogue of errors. And most importantly, for our purposes, the process took up a huge amount of government energy with no space for anything else. Then, in 2019, Boris Johnson was elected Prime Minister. He appointed ministers based on their loyalty to him. We can clearly see that many were far out of their depth. Commentators have remarked on how this is probably the cabinet with the least amount of talent in recent history. And he personally was distracted by his divorce and the pregnancy of his new partner, so he missed many of the key meetings. So this was what was happening. The lockdown was imposed in late March, but it was rather later than in many other countries in Europe. And there are a whole series of analyses, our work and others, which suggest that even a few days earlier would have made a very large difference. In the week before the lockdown, there were a number of high-profile sporting events, and there have been a number of clusters of infection clearly linked to them subsequently. The number of deaths went up rapidly. It did come down and has continued to be low, but it is now rising once again, unfortunately. So what did we see as the characteristics of the pandemic in the UK? First, the initial phase was quite generalised, spreading to all parts of the country. This was very different from the situation in Italy, where it was confined largely to the northern regions, and in France and in Spain, where again it was largely limited to Paris, to Madrid, to the east of France, and to some parts of the Mediterranean coast. It was closely associated with deprivation. The rates of infection were greatest in the poorest areas, but the impact of both the direct and indirect effects, the lockdowns, the loss of employment and so on, were also greatest for poor people. The greatest impact by far was on ethnic minority population. There was an increased risk of both becoming infected and of dying, even when one adjusted for deprivation. Here it's worth noting that the United Kingdom is one of the few countries that does collect these data. So almost certainly this was happening elsewhere in Europe, but we didn't see it. The second phase, when it came in September, was concentrated at first in the northwest, and we now know that this was where the lockdown was lifted prematurely. The initial response was shaped by what could be seen in Italy. There were television pictures every evening of intensive care units being overwhelmed. There was a recognition that the NHS had come into the crisis with a severe shortage of resources. As a consequence, the emphasis was very much on protecting the NHS. It was also very much influenced by previous plans for pandemic influenza, and in this respect it was very different from the situation in Asia. In Korea, of course, you had the experience with MERS. In other parts of South and East Asia, there was the experience with SARS. But the modelling that had been done, the plans that had been made, were very much based on pandemic influenza, with a focus on hand washing in particular, rather than on looking at issues around ventilation and airborne spread. The slogan that was adopted by the government, "Stay home, protect the NHS and save lives," indicates the very high priority given to safeguarding the National Health Service. So what were the initial problems? Well, I want to focus here on the evidence for policy. The government was informed by its Scientific Advisory Group on Emergencies. This is a group that is brought together when there is a severe threat. The membership of the advisory group depends on the threat. So in the case of a pandemic, it includes experts on epidemic modelling and viruses. In the case of a chemical threat, it would be experts on chemical contamination and so on. The membership was initially secret, and so was the advice that was given. This created quite a bit of controversy because the media, civil society and others could not judge what the advice was and to critique it and to ask if the policy followed from it. In response, an independent SAGE was created by a group of concerned researchers, of whom I am one, and we began meeting in public sessions. Unlike the official SAGE, we decided what questions to answer, and we published arguments for our recommendations. Now, in practice, our recommendations have been very similar to those from the official SAGE. We're looking at the same evidence, and we're coming to the same conclusion. The difference is that we can decide what questions to answer. The government responded very quickly, and they started to publish the names of those participating in the official SAGE. Not all of them. There were some political advisors present that was controversial too. And they started releasing minutes of the meetings. And I want to move on to the elements of the response. I want to start with the testing and tracing. You will recall that I said that governments had been contracting out services for many years. Consistent with this approach, the government completely ignored the existing public sector capacity. It disregarded laboratories in hospitals and universities, many of which had capacity to provide testing. The veterinary laboratories in particular had a lot of capacity, but they were not included. It ignored the contact tracers who already existed in local public health teams, in sexual health clinics, and so on. It issued a series of contracts with outsourcing and accountancy firms that had no experience whatsoever in large-scale testing or contact tracing. Once these companies were operating, which took some time, there was a complete failure to establish links to local government, to the National Health Service, or to other stakeholders. That meant that when the local government contact tracers did start working at their own initiative, they were unable to get the data they needed to work with. The contracts were shrouded in secrecy. We knew that the companies involved were not performing well, but it was very difficult to know what they had been asked to do. This newspaper headline tells you exactly what the problem was. It was a shambles. And you can see a testing centre with nobody attending. The testing capacity consistently failed to manage the promises that were being made by ministers. They kept predicting that there would be so many tens of thousands of tests on a particular day, but these were not achieved for many months. At one point, several thousand reports were lost because they were being entered into an Excel spreadsheet. They weren't being entered in by row, but by column, and the capacity of the spreadsheet simply ran out. Now, this shows you how amateurish the whole operation was. The contact tracers were based remotely, and they were attempting to contact cases by phone. Normally, we would expect contact tracers to be out on the street. They would be trying to track down the source of an outbreak. They would be talking to people. They would be finding out where they worked and where they lived, but none of this happened. The contact tracers simply contacted those people who had a positive test and asked them to get in touch with those people who were close to them and asked them to isolate. There was a very low success rate from all of this. The government also prepared for the pandemic by building a number of new hospitals. It took over conference centres like this and fitted them out with beds and ventilators and water supplies and so on. In fact, by the time that these were put in place, the demand was much less than expected, and they did treat a small number of patients, but very few. They are now being kept on standby for a further resurgence of disease. The government put in place a number of measures in the economy. It recognised that people were at risk of losing their jobs. It established a job retention scheme, which was called a furlough, and this was a system by which people were paid 80% of their wages for up to £2,500, about $3,000 per month. The government also wanted to make sure that employees did not fire workers during the pandemic, so it offered the employers £1,000, about $1,400, for every worker who the employers kept on until the scheme ended. There was another scheme to help to get young people into the workforce, paying the minimum wage for 6 months up to 25 hours a week. And there were a series of loans for businesses that were facing closure because of the pandemic. There were different schemes for large and for small businesses. There were also a number of schemes for self-employed people. The problem was that while all of these schemes were very helpful, many people were in the informal economy. They had short-term contracts, 0 hours contracts, and they failed to benefit from this. So there were a lot of people who were really struggling with rent and with the ability to afford food and so on. Was there a strategy? Well, not really. The government never really came up with a coherent strategy. We on Independent Sage had recommended a comprehensive strategy that would include finding cases, testing people, tracing contacts, isolating those who were infected and supporting them. In practice, there was very little finding going on, particularly of people in high-risk settings. We had argued that we should identify these settings and test people proactively. They have put in place a regular testing system for health and social care workers, but there have been major problems with supplies. Other public-facing groups, like taxi drivers, have been excluded. The testing system simply has not worked well at all. People have been directed to testing centres hundreds of kilometres away from where they live. Often the tests ran out. There were some mobile testing units run by the army, but then they were handed to a private contractor and they failed. The contact tracing identified very few contacts, and less than 1 in 5 people who should have isolated did so. There was very little support for those who were isolating. There have been major problems with procurement of personal protective equipment, of test kits, of medicines, and so on. Procurement is still governed by European procurement law, at least until the end of 2020. The government was able to use provisions in the regulations that allow it to bypass the tendering system in emergencies. Contracts were let for many millions of pounds, but without advertising or competition, and there were many failures. So, for example, the government was offered 2 million antibody kits by a Chinese supplier for $20 million. The money was to be paid in advance, and the UK would arrange collection. Boris Johnson described them as simple as a pregnancy test. They didn't work. The UK ordered 400,000 items of protect equipment from a Turkish t-shirt manufacturer. It sent the Royal Air Force to collect them. After many delays, 10% were delivered, but many were unusable. Moving on, new messaging has been adopted. Stay alert, control the virus and save lives. Unfortunately, this has created considerable confusion. How do you stay alert with an invisible virus? As the lockdown was lifted, there were increasing questions about the evidence for what was being done. There has been overwhelming support for restrictions, but there is a vocal fringe minority who are opposed, often linked to extreme libertarian American groups. So how are we doing compared to other countries? Well, not very well at all. Germany and Italy have seen some increases, but they have been able to control the infection much more than the UK, Spain or France. In Spain, there's some evidence that it's turning around, but unfortunately in the UK, it is continuing to rise. We have a problem. Did anything go well? Yes, it did. In research, the UK has world-leading teams. The Oxford vaccine was one of the first to enter phase 3 trials. The recovery trials have meant that most patients treated in the National Health Service have been entered into drug trials. The National Health Service has done remarkably well, despite it being starved of resources for years. There's been a phenomenal effort by the staff involved. They've worked to convert hospital facilities to expand intensive care facilities, and they have introduced new staffing models. They've put in place systems for rapid learning from experience so that good practice can be shared across hospitals. The local public health teams have set up their own tracing systems despite the major obstacles that have been put in their way. So let's summarise where we are. The pandemic hit a country that was essentially failing. The government was in disarray. The civil service was overstretched. There was an initial failure to get the Prime Minister to focus on the threat. He was absorbed in the discussions around Brexit and in his own personal problems. There was a failure to develop a comprehensive strategy. There was a failure to protect residents of long-term care homes, where many of the early deaths occurred. There was a failure to build on existing capacity in testing and contact tracing. There were multiple procurement failures. But there were some successes. There were phenomenal efforts by National Health Service and public health staff, despite these political failures. And the consequence, unfortunately, is that the United Kingdom has had one of the highest death rates in the world, and now, unfortunately, has an epidemic that is out of control. Thank you very much indeed.